So starting off with the GI surgery, the first topic is obviously going to be the esophagus. Now the esophagus is extent of the esophagus is from C6 to D12. It is about 25 to 30 centimeter. And talking about the anatomy of the esophagus, first is the constrictions of the esophagus. So there are 4 anatomical constrictions and 3 surgical constrictions. The 3 surgical constrictions, they are at 15 centimeter, 25 centimeter and 40 centimeter distance from the upper central incisor. So at 15 centimeter, the first constrictor, that is the cricopharyngeus, which is the narrowest portion of the esophagus. Then at 25 centimeter, there is a crossing of the left brainstem bronchus and a aortic arch. And at 40 centimeter, it pierces the diaphragm at T10 level. So what are the different diaphragmatic openings? It is given by mnemonic I8, 10x at 12. So at the level of T8, there is a diaphragmatic opening for the inferior vena cava. And at T10 level, it is for esophagus, and at T12 level, there is opening for aorta and a thoracic duct. Talking about the blood supply, the esophagus is divided into 3 parts: the upper 1/3, middle 1/3, and the lower 1/3. Upper 1/3 is called as the cervical part, the middle 1/3 is called as the thoracic part, and the lower 1/3 is called as the abdominal part. Talking about the arterial supply and the venous supply. So arterial supply in the upper 1/3 is the inferior thyroid artery and inferior thyroid vein. Then for the thoracic, that is the middle 1/3, it is going to be the descending thoracic aorta and the azygous vein. And for our abdominal, it is the left gastric aorta, left gastric artery and left gastric vein. Then lymphatics, it drains into superficial lymphatics, which are longitudinal in nature, and thus there can be skip metastasis here. Histology, we know that the esophagus, it lacks the outermost serosa layer. Instead of it, it consists of tunica adventitia, and the submucosa layer is going to be the strongest. Now the sphincters, there are 2 important sphincters: upper esophageal and the lower esophageal sphincter. Out of which upper esophageal sphincter, it acts as both anatomical as well as physiological sphincter, and the pressure over here is about 60 mmHg, while the lower esophageal sphincter is not anatomical sphincter, that is, there is no constriction over here. It just acts as a physiological sphincter with a pressure of about 6 to 26 mmHg. Now the site for Killian's disease is in between the thyropharyngeus, which is, and the cricopharyngeus. Now peristalsis, there are 3 types of peristalsis: a primary peristalsis, secondary peristalsis, and tertiary peristalsis. Primary peristalsis is a propulsive wave which normally leads the food particles to go forward. Secondary peristalsis is again a propulsive wave which helps the remaining food particle to move forward, while tertiary peristalsis is not propulsive in nature. Then talking about the pathologies, the first is going to be the foreign body. The foreign body can either lodge into the trachea or into the esophagus. This can be differentiated with the help of X-rays. So on the X-ray AP view, on the trachea it will look like this, while on the lateral view in the trachea it will look like this. So this will help us to differentiate between trachea and esophagus. Very important is, if a foreign body, it is impacted at C6 level, and if the patient is symptomatic in nature, in that particular case we have to go for rigid bronchoscopic removal for that foreign body. If that particular foreign body goes beyond C6, that is, it crosses the cricopharyngeal junction, and if the patient is asymptomatic, then in that particular case you have to just monitor the patient, and means conservative management is done. Now if it's going to be a metallic foreign body or a vegetative foreign body, in that particular case you have to go for a emergency rigid bronchoscopic removal. Next is the corrosive. So the corrosive, we know that the alkali are more dangerous than the acids. Alkalis, they are going to damage the esophagus mainly, while the acids, they will lead to formation of eschar at that particular site, and because of which there is no further infiltration, and so it goes down and it affects the stomach. Whenever there is a corrosive poisoning, there should not be any blind nasogastric tube insertion, no IV prophylactic antibiotics, no steroids, while a skilled endoscopy is done within 2 days. Management, the definite management is nothing but a stricture management, because most of this corrosive poisoning leads to strictures. So there is either a ballooning dilatation or esophagectomy that is done for this. Now grading is given by Zergar. So the grading is called as Zergar's grading. 0 is considered to be normal, 1 is just erythema, then 2 is superficial ulceration, 3 is deep ulceration. Superficial ulcerations, they involve the mucosa and the submucosa. Deep ulcerations, they are transmural in nature, and the 4th is perforation. Then the next pathology is the tracheoesophageal fistula. The tracheoesophageal fistula, there are different types. the type A, it is where both proximal and distal esophageal atresia is present. Type B, there is a proximal tracheoesophageal fistula while the distal atresia, remember it as BP. Then type C, which is the most common type, where the distal tracheoesophageal fistula and the proximal atresia is present. And type E or type H is where both of proximal as well as distal, they will lead to tracheoesophageal fistula. And in type F, there is just a esophageal stenosis. So this tracheoesophageal fistula, it is associated with N-MYC gene mutation and also with bacterial abnormalities, that is vertebral. Then E stands for anorectal malformation, C stands for cardiac abnormalities, TE stands for tracheoesophageal fistula, R stands for renal abnormalities, and I stands for the limb abnormalities. Clinical features, there will be coiling of the nasogastric tube, drooling of saliva, and respiratory distress. Diagnosis done by the contrast. Generally, the contrast that is used or safe injector is the iohexol contrast. Now, the contrast that is used in adults is a gastrografin. Now, this gastrografin contrast is used in GERD, that is gastroesophageal reflux disease. It will in achalasia cardia, it will lead to Brodbeck appearance. Then diffuse esophageal spasm, it will lead to corkscrew appearance, and for esophageal cancer, it will lead to rat tail appearance. Investigation of choice for H type. For specifically for H type, we can go for combined tracheoesophagoscopy because there is going to be fistula for proximal and distal both. If stomach air is seen on the X-ray, then that means there is going to be a tracheoesophageal fistula in the distal part. So stomach air, it can be seen in type C or further. Then the next is the management. So management, it is based on the Waterston's criteria. So if the weight of the child is more than 2.5 kg, then upfront surgery is recommended. If it is 1.8 to 2.5 kg, then you have to build up the weight by giving prophylactic antibiotics and then go for surgery. While if the weight is less than 1.8 kg, then gastrostomy tube is applied and then go for the management. So the management is, if there is a atresia on the both sides, then you have to anastomosis it. If they are close to each other, simple anastomosis can be done. If the two ends are far away from each other, then we use a flourish device, which is a magnetic device, as well as gastrostomy, or the feeding tube is made so that the two ends grow towards each other, and then finally we go for anastomosis. Then for the other types, that is B, C, D, E, we go for a special surgery that is called as Cameron Height surgery, wherein wherever the fistula is present, we go for fistulectomy, then repair the trachea with a polydiaphragm suture and anastomose it. For Cameron ulcers, these are the ulcers that are present at a level of diaphragmatic constriction. The next pathology, and a very important pathology, is the GERD, that is gastroesophageal reflux disease. The gastroesophageal reflux disease is prevented because of protective effect. The natural protective effect is the pinch effect, diaphragmatic Crurat's pinch effect, and a minimal intra-abdominal length of 3 to 5 centimeters is maintained. Similarly, there is a constriction of the gastroesophageal junction and H. pylori. These are going to be the protective factors against GERD. If the pressure of the distal junction it less than 6 mmHg, then that also increases the chances of GERD. Similarly, there is just opposite thing to this, that is hypertensive lower esophageal sphincter, where the pressure is more than 26 mmHg. Clinical features of GERD is that it leads to retrosternal burn or the heartburn. There is water brash, that is a bitter taste that develops in the mouth. Then dental caries can happen because of recurrent reflux. So the triad for these symptoms, they are given by this mnemonic HER, where it stands for heartburn, E stands for the epigastric pain, and R stands for the regurgitation. Risk factor is going to be the obesity. The investigation of choice is the upper GI endoscopy. The gold standard is 24-hour pH monitoring. Then you can put a pH probe. A dual pH probe can be put in the trachea and esophagus. This helps in good monitoring. Then if the Demister score is more than 14.72, then also it is diagnostic of GERD. And medications can be given and followed by that surgery. So surgery, the operation is fundoplasty. So you have the Nissen's fundoplasty. So you have to wrap the fundus in fundoplasty, which is called as a French bougie wrap or a shoeshine maneuver. There are different types of fundoplication operations. So Nissen's fundoplication is 360-degree posterior. It can lead to gas bloat syndrome. Floppy Nissen can happen if it is not very tight, and laparoscopic Nissen is going to be the best. Then just opposite to the Nissens is Rossetti Hall, which is 360-degree anterior. Then the door is 180-degree anterior. Tuppet is 180-degree posterior. Uh, Belsey mark is 270-degree anterior. Watson is both anterolateral, and anterior as well as posterior is the lint. Then another operation is called as the gastroplasty. It is called as Colles gastroplasty, when the esophagus is short, that is less than 2 cm is its intra-abdominal length. The newer modalities include the polymer injection, which tighten the sphincter, endoscopic radiofrequency ablation, then LINX device or natural orifice, transluminal endoscopic surgery, that is NOTES. Most common cause of peptic strictures is the chronic GERD. Complications of GERD, there will be the Barrett's esophagus. Barrett's esophagus is also called as the cardiac metaplasia, where the squamous cell epithelium changes to intestinal columnar epithelium. There's a red velvety colored mucosa, and the reflux esophagitis. The classification that is used is the Savary-Miller classification or the Los Angeles classification. Chromoendoscopy can be done. By chromoendoscopy, the Lewis iodine is used. Now this iodine is going to stain the glycogen, so it stains in the normal cells, but in case of dysplastic cells, the glycogen stores are used up, and because of which in these particular cases there will be no staining. Then the Prague's CRM criteria as well as the Settle's biopsy criteria is used. Similarly, another stain is the methylene blue, which is going to stain the area of carcinoma. Then what is the management algorithm for Barrett's esophagus? You have to go for a cooled endoscopic biopsy. If there is no dysplasia that is found, then you have to repeat after 3 to 5 years. Then if it's a low grade dysplasia, then you have to go for a radiofrequency ablation and followed by endoscopy after every 6 months till 2 consecutive margins to come out to be negative. Repeat after 3 to 5 years. Then if it's a high grade dysplasia, you have to again go for radiofrequency ablation, discuss with a multidisciplinary team, and go for esophagectomy. And infections, candidiasis or oral thrush, and other is the CMV, that is cytomegalovirus post-transplant. In candidiasis or oral thrush, there is a worm-like ulcers, or in CMV, there are serpiginous ulcers or geographical ulcers. And in feline esophagus, in the upper one-third, there is eosinophilic esophagitis, where it shows a crepe paper mucosa, furrows at rings. The eosinophil numbers are more than 15 to 20 per hyporphin, and there is a stacked up appearance. In lower one-third, it shows the features of GERD. Then moving next to the motility disorder, the most common motility disorder is the achalasia cardia. There is an increased risk of squamous cell carcinoma, while GERD increases the risk of adenocarcinoma. Then there is a gradual loss of the ganglion cells. It is not similar to Hirschsprung disease, where there is a congenital absence. And there is another syndrome that is called as nutcracker esophagus. In nutcracker esophagus, there are normal peristalsis, but however, the amplitude of contraction increases, and the duration is also more than 6 seconds for distal contractions. So that is called as the nutcracker esophagus. Then motility disorders, the primary achalasia cardia is because of primary causes. Then secondary achalasia is caused because of associated with trypanosoma cruzi infection causing Chagas disease. Pseudoachalasia is associated with malignancy. Then there is a AAA syndrome. The AAA syndrome, it includes the alacrimia, achalasia, and adrenocorticotrophic hormone resistant adrenal insufficiency. In all of this, they grow with time, and AAA syndrome is also called as the Olgrow syndrome. Then there is a triad of dysphagia. Dysphagia in the achalasia cardia is poor for liquids as compared to solids. Then there is weight loss, and earliest feature, that is the regurgitation. The most common complication is aspiration pneumonia. Investigation of choice is the high resolution manometry. On high resolution manometry, there is a integrated relaxation pressure of more than 15 mmHg. Based on it, there is a Chicago's criteria. In Chicago criteria, considering the elevated IRP more than 15 mmHg, there is type 1 achalasia, type 2 achalasia, and type 3. So type 1, there are 100% failed peristaltic contractions without panesophageal pressurization. In type 2, there is 100% failed peristalsis with panesophageal pressurization in more than 20% swallows. And in type 3, it is also called as spasmodic achalasia, wherein more than 20% percent swallows, they show premature spastic contractions. Here, the DCI, that is distal contracted integrals, it is more than 450 mmHg, and it shows a jackhammer appearance. So there is a specific score that is called as the Achillea-Icard score, wherein the uh, parameters are regurgitation, retrosternal pain, weight loss, and dysphagia. The management, if it's an old patient with comorbidities, then go for Botox. However, there are high chances of recurrence. Then balloon dilatation or pneumatic dilatation can be done, generally done in more than 45 years, females and type 2. Then definite surgical management is Heller's myotomy or peroral endoscopic myotomy, that is POEM, which is a Notes procedure. Here we have to resect a tissue up to 6 centimeters above the G junction and 2 centimeters below. However, there is increased risk of GERD complication while doing these surgeries. So if it's going to be type 1 achalasia, we have to go for Heller's myotomy. If it's a type 2, then Heller's myotomy plus pneumatic dilatation, and type 3 POEM is done. And the next pathology is distal diffuse esophageal spasm or distal esophageal spasm. Here is a normal peristaltic contraction with a delayed relaxation. The DCI is increased. The very important buzzword that is given in the MCQs is there is an angina-like pain or chest pain. Diagnosis on barium solid gives a corkscrew appearance or rosary bead appearance. Confirmation is by panometry. Management is by giving calcium channel blockers, nitrates, or a POEM. Then diverticulae. There are 3 types of diverticulae: upper diverticulae, mid diverticulae, and lower diverticulae. Out of which the upper and the lower, they are pulsion type, pressure type, while the middle is a traction type of diverticulae. The examples of upper diverticulae are the Zenker's diverticulae, which is a false diverticula. Only the mucosa comes out. It is also called as cricopharyngeal achalasia. It increases the risk of squamous cell carcinoma. Then the example for mid is parabronchial, which is due to tuberculosis or histoplasmosis, while in the lower it is epiphrenic diverticula. Now, the upper and the lower, they are false diverticula, while the mid is a true diverticula. The Zenker's diverticulum, the earliest feature is the regurgitation. Most common complication is aspiration pneumonia, and investigation of choice is the barium swallow. Management, if it's large, symptomatic more than 2 centimeters, then you have to go for Dolman's procedure. So in Dolman's procedure, it is a diverticulectomy by using a linear stapler and cricopharyngeal myotomy, that is that mass is removed out. Or if it can be endoscopic diverticulopexy and cricopharyngeal myotomy. Next pathology is the hiatal hernia. The hiatal hernia, the clue, the buzzword that is given is a intrathoracic gas bubble that is seen on the chest X-ray. Most common type is the sliding type, and most common congenital is the Bostalich type. It is a part of the Saint triad. In the Saint triad, there is going to be SDG, that is sliding hiatal hernia, the diverticulosis, and the G stands for gallstones. Now, type 1 hiatal hernia, that is called a sliding hernia, which is the most common. Here, the gastroesophageal junction slides above the diaphragmatic level. So, there are increased chances of GERD. Investigation of choice is contrast enhanced CT. Then, next, type 2 is the rolling type of the paraesophageal type. It is found in elderly. It is associated with hiccups, early satiety, and postprandial bloating. The complications are this herniated part of the stomach. It can undergo volvulus perforation, or there can be ulcers, that is called as Cameron ulcers. Then there is pill-induced esophagitis. The pill-induced esophagitis generally affects the mid-esophagus. Then the next pathology is the perforation. So perforation, it can be iatrogenic or it can be spontaneous. The iatrogenic, that is surgery-induced perforation, is more common. Investigation of choice is CECT. It is generally post-endoscopy that will lead to chest pain. More commonly, it is seen in the upper 1/3 region. If the patient is stable, then go for IV fluids, prophylactic antibiotics, NPO, pain management. However, nasogastric tube should not be inserted because if the perforation is small, you can make it large. If it's an unstable patient, that means a large perforation is present, in that particular case, we manage it by endoscopic sealing with clips or SEMS, that is subendoscopic mucosal stents can be used. But however, the most common complication with the stents is that they can lead to migration. Similarly, surgical repair of the perforation can be done, or repair over the T tube is done. The cervical perforations, which are often by the nasogastric tube, they can be managed conservatively because of small openings. Now the spontaneous perforations are more common in the lower one-third region and associated with Boerhaave syndrome. So Boerhaave syndrome, the triad for Boerhaave syndrome is the bacular triad. And so in the bacular triad, there is going to be chest pain, then the retching, that is forceful vomiting, and subcutaneous emphysema. Investigation of choice in stable patient is CCT. On stable patients, we give a oral contrast. Now this oral contrast generally is iohexol because it is safer. If there is a perforation, then we can go for endoscopic sealing at that time. At that point, this contrast can lead to pneumomediastinum, then continuous diaphragm, and an acylarios V sign. This can be seen on chest X-ray. So on the chest X-ray, pneumomediastinum, acylarios V sign, and continuous diaphragm can be seen. Again, the management is the same, that is endoscopic sealing, then esophagostomy or repair over the T-tube. Now, the sub-miscellaneous topics include a Shaskey ring. Shaskey's ring, there are three types A, B, C. A is muscular, B is mucosal, and C is associated with sliding hiatal hernia. Now, out of which the B is more very important. It is present in the lower esophagus. It will lead to intermittent dysphagia, which is non-progressive in nature. Management is by balloon dilatation. Another condition that is called as dysphagia lusoria. This is because of compression of the esophagus by the right subclavian artery, aberrant right subclavian artery. Now coming on to the next topic, that is cancers. So in the cancers, the benign cancers of the esophagus is called as the leiomyoma. Investigation of choice is the barium swallow, which will show a punched out appearance, and management is stirred, that is submucosal tunneling and endoscopic resection. Talking about the malignant type, there are multiple risk factors that are noted. First, common cell carcinoma and adenocarcinoma, out of which in common cell carcinoma, remember, achalasia cardia is a very important, and in adenocarcinoma, it is going to be the obesity, right? All the Barrett's esophagus related, GERD related complications, and very important, scleroderma or the CREST syndrome, it increases the chances of adenocarcinoma. Earliest clinical feature is the progressive dysphagia for solids greater than liquids. Then, if there is a left recurrent laryngeal nerve involvement, that leads to hoarseness of voice. Investigation of choice is endoscopic biopsy. Investigation of choice for TNM staging is the endoscopic ultrasound. And barium swallow, it will show a rat tail appearance or apple core appearance, that is shouldering effect on the seen. And staging is done by the PET-CT. And the TNM staging, so the TNM staging, T1A involves the mucosa, T1B submucosa, and T2 muscularis, T3 tunica adventitia, T4 it has gone to the extra spaces, T4A, that is resectable spaces like the diaphragm, pleura, and the pericardium, T4B it invades the aorta, trachea, and the vertebra. Then N1, that is 1 to 2 lymph nodes are getting involved, N2 3 to 6 lymph nodes, and N3 more than or equal to 7 lymph nodes. Well, the most common site of metastasis is going to be the liver. Now it's a T1A involving only mucosa. Then EMR can be done, that is endoscopic mucosal resection. For T1B, where it involves the submucosa, then esophagectomy is required. For T2, T3, and T4 tumors, first we have to go for a chemoradiotherapy followed by surgery. The Sievert's classification. So Sievert's classification is based on the gastroesophageal junction. So 1 centimeter above and 2 centimeter below the gastroesophageal junction, if there is a cancer, that is called as Sievert's class 2. In Sievert's class 1, that is more than 1 centimeter above, and more than 2 centimeter to 5 centimeter below, that is called as the class 3. So class 1 and 2, they are considered to be esophageal cancers, while class 3 you have to treat it as a gastric cancer. Then talking about esophagectomy, there are different types of esophagectomy. There are three types. For upper one third is a transhiatal or Oringer type. Then Ivor Lewis approach for middle one third, and for middle one third the best is actually Mackion's threefold. Now it is based on the number of sites and incision, and which is the site of anastomosis. So the transhiatal or the Oringer type, the number of incision there, the 2, and the site of anastomosis is going to be upper midline incision and an incision at the left neck. While in the Ivor Lewis approach, there are again 2 incisions, that is upper midline and a right thoracic. While in the Mackion's threefold, there is going to be upper midline, right thoracic, as well as left neck. Now, in the Ivor Lewis approach, the complications can be anastomotic leak. It can lead to mediastinitis, which is the most common cause of death. While in Mackey's 3 field, the most common complication is the stricture formation, and it can also lead to atelectasis and pneumonia. Minimum number of lymph nodes that are removed in esophagectomy are 15. Then esophageal replacement is done by the stomach tube, which is based on right gastric artery and right gastroepiploic artery. The anastomotic leak, it happens at the neck greater than the thorax, while if it happens in the thorax, then that is going to be the most dangerous of all. Then the next is the stomach. So in the stomach there are different arteries having. So the left gastric artery is a branch of the celiac axis. The right gastric artery is a branch of the common hepatic artery. The left gastroepiploic artery is a branch of the splenic artery. Right gastroepiploic artery is a branch of the gastroduodenal artery. Right gastric artery and right gastroepiploic artery, they form an extensive submucosal anastomosis, and because of which they are used as a stomach tube. Out of which the right gastroepiploic artery is more important. Then, talking about the pathologies, the first is the CHPS, congenital hypertrophic pyloric stenosis. It generally happens in the firstborn male child, associated with Apert syndrome, then Cornelia de Lange, decreased nitric oxide synthesis levels, and erythromycin. Initially, the patient is asymptomatic for 2 to 3 weeks. Now, this is something that makes it different from the duodenal atresia. In duodenal atresia, the child is symptomatic from birth itself, while in CHPS, the patient is asymptomatic for the first 2 to 3 weeks. Then there is a projectile non-bilious vomiting. On examination, during the breastfeeding, there is only shoot mask, and there is a peristalsis that happens from left to right. The investigation of choice is the ultrasound. On ultrasound, the pyloric muscle thickness is more than 4 mm and the length is more than 16 mm. Contrast. On the contrast, there can be double track sign, string sign, or a mushroom sign is seen. On X-ray, single bubble appearance. Electrolyte abnormalities, it will lead to hyponatremia, hypokalemia, hypochloremia, metabolic alkalosis with a paradoxical aciduria. This is the most important. Then management, half normal saline, dextrose or ringer lactate solution is given. Surgical management is the Ramsted's pyloromyotomy. If it is uneventful, that is, there is no complications during surgery, we can start feeding within 4 to 6 hours. But if there is a mucosal injury, then feeding is done in 24 to 48 hours. Now, very important, you have to cut the muscle there and you have to go up to the mucosa, but you should not injure the mucosa in this surgery. Then the next is going to be the peptic ulcers. So in the peptic ulcers, the duodenal ulcers, which are the most common site for duodenal ulcers is the D1, that is first part of duodenum. It relieves with food. Complications are bleeding is the most common, and it is most commonly seen with the posterior ulcer. There are two types of ulcers, either anterior or posterior. So P not for P. So posterior ulcer, it leads to bleeding, while perforation seen in anterior ulcer. The bleeding artery is the gastroduodenal artery, is the most common cause of upper GI hemorrhage. Perforation, anterior ulcers, and the management is the Gram's repair or the Homental patch repair. Then the posterior ulcer, it shows a renal vein sign, or it shows a Valentino syndrome, that is, which mimics the appendicitis. Then cauterization. Cauterization is a procedure that is used to mobilize the duodenum to view the posterior ulcers. In the gastric ulcers, the classification is given by Johnson. So there is Johnson's classification. So class 1, it lies along the lower curvature, and it is close to incisura. Class 2, it is pre-pyloric plus duodenal. Class 3 is only pre-pyloric. Class 4, it lies high up, and in class 5, it is diffused because of NSAIDs. Now the management is important. In the class 1, it is distal gastrectomy along with Billroth 1 or Billroth 2 procedure. In class 2, which is pre-pyloric plus duodenal, or class 3, which is only pre-pyloric, it is because of acid hypersecretion, because of which proton pump inhibitors or vagotomy should be done along with distal gastrectomy. In class 4 or 5, there can be bleeding present or absent. Here, the procedure that is done is the Pochette procedure or Kaling-Madlener procedure, or the Sentis procedure. So Pochette, Kaling-Madlener, or Sentis procedure along with gastrojejunostomy or Roux-en-Y surgeries. Most common complication is to perforation in gastric ulcers. Now, vagotomy. So before vagotomy, you should know what are the branches of the vagal nerve. So the vagal nerve, it divides into two trunks, anterior trunk and a posterior trunk. Anterior trunk, it supplies or gives the motor branch to the gallbladder that helps in secretion, that helps in forward moving of the secretions of gallbladder. Similarly, it's a motor branch of the pylorus and anterior nerve of lateral jet. The posterior branch it gives of posterior trunk it gives of the criminal nerve of Krasi, which is very important for recurrence. There is a posterior nerve of lateral jet and multiple crowfoot branches that supply the antrum. There are two types of vagotomy. So there is a truncal vagotomy as well as a antrectomy and a highly selective vagotomy. In highly selective vagotomy, the acid reduction is low, while in truncal vagotomy or radical one, there is maximum. Also, recurrence chances are more in highly selective, complications are less in highly selective. Indications are chronic ulcers in highly selective, while in truncal vagotomy, we should go for recurrent ulcers. Now, what are the complications? The complications of doing vagotomy are nutritional complications, wherein the iron deficiency anemia is the most common. Apart from that, can lead to deficiency of B12 as well as calcium. Anastomotic leak. Now, talking about these procedures, that is the Billroth procedure. So in the Billroth procedure, there is Billroth 1, that is called as gastroduodenostomy, wherein distal gastrectomy is done and end-to-end gastroduodenal anastomosis. Billroth 2 procedure, its modification is called as the Polya procedure, wherein subtotal gastrectomy or partial gastrectomy is done and end-to-side gastrojejunal anastomosis is done. So that is also called as gastrojejunalostomy. While the Roux-en-Y surgery, where the Roux limb is created, which is nothing but gastrojejunalostomy, and then a BP limb, that is a biliopancreatic limb, is created after a subtotal or partial gastrectomy. The minimum length that is to be kept at 50 centimeter. Lateral lengths they vary according to the status of the person. So there is a end to side gastrojejunal anastomosis and side to side jejunal anastomosis that is seen in Roux-en-Y procedure. The mobilization of the jejunum, it can be either anticholic or retrocolic in nature. If it's anticholic in nature, then that increases the chances of AP, that is Peterson's hernia. When retrocolic, it increases the chances for Streimer's hernia. Then the complications are related to these procedures. The most common is the nutritional, wherein the most common is the iron deficiency anemia, B12, and the calcium deficiency. Anastomotic leak is seen in Billroth 1 greater than 2. Duodenal stump blowout, that is seen in Billroth 2 procedure and Roux-en-Y procedure. It is generally seen on postoperative day 4. Bilious vomiting in Polya procedure. Jejunal ulcers can happen. Afferent loop syndrome in Polya. Bilious vomiting is associated. Osmotic diarrhea, gallbladder stones, internal hernias, that is Peterson's or Streimer's hernia, and a very important dumping syndrome. The dumping syndrome is seen in Billroth 2 or Polya greater than Roux-en-Y. Here, it can be early dumping or the late dumping syndrome. The features of early dumping syndrome are the nausea, vomiting, and bloating. Onset is 10 to 15 minutes, and the relation with the food is that it worsens with extra intake of food. Late, it leads to rebound hypoglycemia, headache, and sweating. It is about half an hour later, and it relieves with more food. For that, first you have to do diet modifications. If not octreotide, or if still it's not working, then you have to convert this Billroth 2 or the Polya procedure into a Roux-en-Y procedure. Next is the bariatric surgery, which is also called as the metabolic surgery. It is called as the metabolic surgery because it leads to reversal of the metabolic diseases like diabetes or hypertension, along with decrease in the obesity. So indications for bariatric surgery are important. If there is a BMI of more than 40, BMI of more than 35, it is associated with morbidities like hypertension, obesity, obstructive sleep apnea, or osteoarthritis. If the BMI is more than 30, along with type 2 diabetes within 10 years, the pre-op consideration should be a liver shrinkage diet is given first, then smoking cessation and oxygen is given in OSA patients. Now there is a score that is called as OSMRS, that is obesity surgery mortality risk score. Every parameter gets 1 point. The parameters are age more than 45, then male, then BMI of more than 50, hypertension, and the risk factors for pulmonary thromboembolism. Then the bariatric surgery, there are 3 important mechanisms by which this happens, that is, out of which the most important is that it decreases the absorption of food, decreases the surface area for absorption. Then irreversible procedure that includes the subtotal gastrectomy. Subtotal gastrectomy is a end-to-side gastrojejunalostomy along with a biliopancreatic limb that is created. This is called as a BPD procedure. Or there can be DH, that is duodenal switch procedure, wherein a sleeve gastrectomy is done. But however, they are related to maximum complications, and because of which these procedures are now obsolete. Now, the next is this particular procedure where there is a subtotal gastrectomy that is done. Then there is a gastrojejunal anastomosis, and over here bypassed abdomen, and it will lead to jejunal anastomosis. So this is nothing but your polya procedure, Roux-en-Y procedure. And over here we can see that only one anastomosis is made, that is the gastrojejunal anastomosis. So that is called as the mini gastric bypass surgery. The length of the Roux limb, it depends, as I said. In peptic ulcer patients, the minimum length of BP limb or the Roux limb should be 50 centimeter. In bariatric surgery, it should be a minimum of 100 centimeters, and in super obese individuals, it is a minimum of 150 centimeters. Complications: the most common cause of mortality following this is pulmonary thromboembolism. Another complications can be anastomotic leak, nutritional complications wherein iron deficiency anemia is the most common, then there are different hernias and a stricture. Then the laparoscopic sleeve gastrectomy is the most common performed bariatric surgery. Okay, and here the linear stapler is used. Complications over here, the most common is the bleeding. Then nutritional complications, GERD or Barrett's can happen. A DVT-P leak from the angle of face, which is going to be the most distressing complication, and a weight gain due to redistension of the sleeve. So the management for this is the rose, pose or toga. Rose, that is restorative obesity surgery endoscopically, and pose is primary obesity surgery endoscopically, and toga is total gastroplasty, total oral gastroplasty, transoral gastroplasty. Then reversible methods. Reversible methods include the gastric binding or gastric banding. So the band is placed 6 centimeter from the gastroesophageal junction. A part of the balloon, the port. So the port of the balloon is at the level of umbilicus. Complications is that there can be port infection, there can be band infection, or the slippage of the band can happen. Intragastric balloon placement, it is allurion, which is self-dissolving in nature. So order of weight loss is actually better in case of these irreversible surgeries like the BPD or the duodenal switch, followed by sleeve gastrectomy is equal to mini gastric bypass, and followed by gastric binding, which is the least weight loss. The next topic is upper GI hemorrhage. Upper GI hemorrhage. So in the upper GI hemorrhage, the with how to decide whether it's upper or lower GI hemorrhage, it is based on the ligament of Treitz. If it's above the ligament of Treitz, it's upper GI hemorrhage. If it is below, then that is called as the lower GI hemorrhage. The non-varicose causes are more than the varicose causes. The non-varicose causes include the peptic ulcer. In the peptic ulcer, duodenal ulcer is greater than the gastric ulcer. Duodenal ulcer, the artery involved is the gastroduodenal artery, and most commonly the posterior ulcers. When gastric ulcers, it is going to be the left gastric artery. Then there are gastritis. There are different types of gastritis. Gastritis type A, B, C. Then in type A, it is autoimmune. There are antibodies that leads to vitiligo. Then antrum is spared, very important, and E. chlorhydria is seen. While in type B, it is associated with H. pylori, and antrum is affected. Then the stress induced are the curling and the Cushing's ulcer. Curling's ulcer is most commonly seen in the first part of duodenum. Then in the AIDS, the cryptosporidium and the Inicet induced gastritis can lead to upper GI hemorrhage. Apart from that, the Mallory V-steer is because of alcoholism, and the artery involved is the left gastric artery, the side is the gastroesophageal junction, and the extent is mucosa and the submucosa for this ulcer. Then the next is GAVE, that is gastroantral vascular atresia. That is nothing but it leads to watermelon stomach. Management is by argon plasma coagulation. Then portal gastropathy, where the snakeskin appearance or strawberry stomach is found. Then Dolofoy's lesion is submucosal arterioles are going to be dilated. Then Menetrius disease, we know the management is cetuximab. If not, then total gastrectomy is done. Earliest clinical feature is the protein losing enteropathy, and then TGF alpha related disease that leads to cerebriform ruby that we know. Then the next is varicose causes, that includes the splenic vein thrombosis, right sinistral hypertension secondary to pancreatitis, and management is splenectomy. It is caused because of portal hypertension. When we say it has to be portal hypertension, when the hepatovenous portal gradient is more than 12 mm Hg, there are increased chances of rupture. More than 10 mm Hg is where we call it as the portal hypertension. The causes are pre-hepatic, hepatic and post-hepatic. In the pre-hepatic causes, there can be splenic vein thrombosis, then portal vein thrombosis. Then in the hepatic causes, it can be pre-sinusoidal, that includes the schistosomiasis and the sarcoidosis. Sinusoidal, that is any cause leading to cirrhosis, and post-sinusoidal causes, that is the hepatic venous outflow obstruction, or basically veno-occlusive disease. And in the post-hepatic, there is hepatic venous outflow obstruction, Budd-Chiari syndrome, congestive cardiac failure, nephrotic syndrome. These are the causes of portal hypertension. Management is airway breathing circulation. Then IV access should be made. IV terlipressin or octreotide should be given in bleeding ulcers, and then go for endoscopy. So in the endoscopy, there is a band endoscopy greater than sclerotherapy. Sclerotherapy is done by sodium tetraticale sulfate, polidocanol, ethanolamine, or sodium moroate. Now the bleeding stops. Then in that particular case, you have to give a prophylactic oral propranolol or use the tubes. So there are three important tubes: Sextacan Blackmore tube, then the Minnesota tube, and the Linton tube. So in the Sextacan Blackmore tube, there is only one channel for aspiration, while in Minnesota tube there are four channels actually: two esophageal balloon and gastric balloon channel, and the two channels for aspiration for esophagus as well as gastric. While in Linton's tube there are only three ports. Now the shunt, there can be selective shunt or non-selective shunt. The selective shunt, the example it is given by the mnemonic, that is SIW. So selective shunt, I stands for Inopucci shunt, which is based on left gastric artery, and the Warren shunt, which is based on distal linear artery. Now the non-selective shunt, the most common that we perform is the TIPS, that is transtubular intrahepatic aortic systemic shunt, that increases the chances of hepatic encephalopathy. Then Linton shunt is the proximal linear or ECK fistula. Then there is a Suiguira procedure that is not done nowadays, it is obsolete, wherein the whole esophageal devascularization is done. There are multiple prognostic scores. There's bleed criteria, forest criteria, AIM-65, Glasgow Blatchford, and Rockall, out of which the forest criteria is important. So in the forest criteria there is 1, 2, 3. In that there are further subdivisions. So 1A is spurting of the blood, 1B is oozing of the blood, both of them are high risk. Then 2A and 2B. 2A is viable vessel, which is non-bleeding. Then the 2B is adherent clot, which are medium risk, and 2C is a pigmented spot, and 3 is a clean base, which are going to be low risk in nature. Now moving on to the next, that is the bowel obstruction. So there are two types of bowel obstruction, either dynamic bowel obstruction or adynamic bowel obstruction. So the difference between this is mechanical obstruction, which is present in dynamic, and bowel obstruction, that is present in bowel contractions, they are present in dynamic. Bowel sounds, they can be heard in dynamic contraction, and there is a silent bowel that is seen in adynamic obstruction. However, silent bowel is present in dynamic obstruction only when there is a perforation. Upper GI tract obstruction, that will more often lead to vomiting, while lower GI tract obstruction will lead to obstipation and distension. Investigation for X-ray, proximal segment will be distended while the distal segment will be collapsed. An investigation of choice in adults is the CCT. For children, it is going to be the ultrasound. Critical diameters, for small intestine it is 3 cm, for large intestine it is 6 cm, and from the colon or the cecum it is 9 cm. Then definite management, exploratory laparotomy should be done. If the cecum is visualized, if the cecum is found to be collapsed, then that means a small intestinal obstruction. If the cecum is found to be distended, then that means it's a large intestinal obstruction. So cecum is that particular part which helps us to differentiate between the obstruction. Then to look whether it is viable or non-viable. If it is viable, that is, it's pink in color, pulsations of mesenteric artery are present, and if peristalsis is present. And non-viable is the one which has gangrenous appearance, which is dull and lusterless. Then duodenal atresia. Duodenal atresia, the pathology is the non-canalization. The most common type is the type 1 of the duodenal atresia. You have to differentiate it with congenital hypertrophic pylori stenosis. Now, one important differentiating point, as I already mentioned, is duodenal atresia is a start symptom. The baby is symptomatic right from the birth. In duodenal atresia, there is a bilious vomiting that is seen associated with Down syndrome. And investigation of choice is the X-ray, where double vowel sign is seen, and management is the Diamond's duodenostoma. Double vowel sign can be seen in duodenal atresia as well as in annular pancreas. Jejunal atresia. Jejunal atresia, triple vowel sign is seen. Management is resection and anastomosis. The different appearances of the atresia are: in type 3A, there is a V-shaped mesenteric gap. In 3B, it is apple peel deformity or the Christmas tree appearance, and type 4 is a string of sausage appearance. Now, next is the intersusception. So in the intersusception, there are two important things: intersuscipiens, which is the recipient, and in the intersusceptum, that is the donor. Most common site of ischemia is going to be the head of intersusceptum. Now there are two types: primary intersusception and secondary. The primary is more common in children, secondary is more common in adults. Primary it is due to hypertrophy of Peyer's patches, and the most common type is the ileocolic. While in secondary it is because of a pathological lead point, which can be a polyp, which is most common, ulcer, cancer, or a Meckel's diverticulum. And the most common type in adults is the colocolic. Clinical features: there is a drawing up of lips, a red currant jelly stools, sausage-shaped mass, or a sign of dance is seen. In an ultrasound, there is a target sign or a donut sign, and a pseudo kidney sign can be seen. On contrast edema, there is a pincher claw sign that is seen in children. Investigation of choice in adults is the contrast renals CT. For surgery, we have to reduce it. Reduction is done by pushing it and not by pulling it. In secondary or perforation or strangulation, you have to go for resection and anastomosis. Then volvulus, there are two important types of volvulus: sigmoid volvulus or a sickle volvulus. In both of them, the coffee bean appearance is seen. In sigmoid volvulus, it is towards the right side, and sickle volvulus, it is towards the left side, the tip. Then the risk factors for sigmoid volvulus are long mesentery, redundant sigmoid, or loaded sigmoid. The X-ray coffee bean or inner tube, bent inner tube sign is seen. Investigation of choice is CCT. Contrast edema, it shows a bird beak appearance or the ace of spades appearance. The investigation of choice in sickle is CCT, and the management is for sigmoid volvulus. If peritonitis is absent, sigmoidopexy is done. If it is present, then Hartmann's procedure, wherein we first do a resection, then the stoma is created, and 6 to 8 weeks later, reanastomosis is done. Management for sickle volvulus is: if peritonitis is present, right hemicolectomy. If peritonitis is absent, then go for cecopexy. Then strictures. The investigation of choice in adults is the CCT. In children, it is ultrasound. If the two strictures are close to one another, resection and anastomosis of that segment. If the two strictures are far apart from each other, then in that particular case, go for stricturoplasty, which is either a umbilical stricturoplasty or the Finney stricturoplasty. Next is the Meckel's diverticulum. So Meckel's diverticulum, it is basically a remnant of the vitreointestinal duct. Then it is located along the antemesenteric border. It's a two diverticulum. It has got independent blood supply. And there is a rule of two. It is found in 2% population. It consists of two mucosas, stomach mucosa and a pancreatic mucosa. It is 2 feet away from the ileocecal junction, and it is about 2 inches long. Management: if it is asymptomatic, that is a broad based on mouth, then conservative. If it is narrow based on narrow mouth, then diverticulectomy is indicated. Meckel's diverticulitis, it mimics the acute appendicitis. Management is diverticulectomy. Then perforation, in that case, resection and anastomosis is done. It can lead to hernia, that is called as Leiter's hernia. Then bleeding is most common in children. The diagnosis is 99 technician per technique scan, and the management is embolization in this case. Then the obstruction, which is the most common complication in adults, wherein it can act as a pathological lead point leading to secondary volvulus. Management is conservative, and malignancy, it can lead to neuroendocrine tumor. The most common cause of bowel obstruction overall is the adhesive bowel. In the adhesive bowel, the most common cause is post-surgical. Other causes can be TB, Crohn's, or the pelvic inflammatory disease. Management in the first 2 to 3 days conservative, and then go for a definite surgery, that is adhesive lysis. Investigation of choice in adults is CCT, in children it is ultrasound. The next pathology is the meconium ileus. In the meconium ileus, it is associated with cystic fibrosis. Here, the diagnosis is going to be sweat chloride test. On the X-ray image, you can see this soap bubble appearance. Management is by giving this gastrographic enema, and after that doing a definite surgery. The definite surgery for meconium ileus is Bishop-Cook surgery by creating an ileostomy to irrigate it. Then superior mesenteric artery syndrome, SMA syndrome, or that is also called as the Wilkie syndrome or the CAS syndrome. So in SMA syndrome, the normal angle is 25 degree to 45 degree. Less than 22 degree, due to obliteration of the fat, the causes of it are the weight loss and the spinal cast for the vertebra. Investigation of choice of the CT angio. The management is the strong procedure, wherein the cutting of the ligament of trade system. Then there is a Ladd's band. Ladd's band is the most common intestinal malrotational abnormality. The course of the Ladd's band is from the right hypochondrium up to the cecum, and investigation of choice is CCT. Management for this is the Ladd's procedure, wherein the excision of the Ladd's band is done. Then adynamic. In the adynamic obstruction, the examples are the first, it is the paralytic ileus. The most common cause of paralytic ileus are the electrolyte abnormalities like the hypokalemia, hypothermia, and hypothyroidism. Apart from that, post-surgical investigation is CCD, and management is prolonged total parenteral nutrition. Then the next pathology is Hirschsprung disease, where there is a congenital absence of the um, neural crest cells. It is also called as the congenital megacolon. No ganglion cells in the Meissner's pouch or the Auerbach disease. It's a neural crest cell pathology and associated with GDNF mutation, that is glial-derived neurotrophic factor, associated with MEN2A, the abdominal distension or digital rectal examination that will cause passing of the stools, which is seen in Hirschsprung disease. Investigation of choice is going to be a full thickness rectal biopsy, 2 cm above the dentate line should be done. On the IHC marker, it is acetylcholinesterase positive. Barium enema, there are 3 zones: a dilated zone, transitional zone, and a constricted zone. Transitional and constricted zone, there are no ganglion cells. Management, the surgery is the Duhamel's procedure, Swenson's procedure, the Suave's procedure. So, and the intraoperative frozen section is taken. And the next pathology is the mesenteric ischemia. In mesenteric ischemia, there are multiple types. The first is NOMI, that is non-operative mesenteric ischemia. It is associated because with congestive cardiac failure. Then there is a venous mesenteric ischemia due to thrombosis. The vein affected is the superior mesenteric vein, and the virtual stride is seen. Arterial, it is further divided into AMAE and AMAT. AMAE is due to acute mesenteric ischemia because of embolus, and AMAT, that is because of thrombosis, atherosclerosis. The source of embolus is going to be the heart, due to arterial fibrillation. The artery affected is the superior mesenteric artery. Investigation of choice is CT angio. Management, if it's a viable patient, embolectomy. If it's a gangrenous part, then resection, and that usually leads to short bowel syndrome. When AMAT, the artery is affected, that is superior mesenteric artery, postprandial abdominal pain followed by weight loss. Investigation of choice is CT angio, and management is by bypass grafting. Colonic pseudo obstruction, that is also called as the Ogilvie syndrome. It is associated with psychiatric medications or neurological conditions like Alzheimer's, Parkinson, or retroperitoneal trauma. Retroperitoneal trauma leads to something called as meteorism, wherein there is abdominal distension for 3 to 4 days even after surgery. Management for Ogilvie syndrome is IV neostectomy, and the regime is called as a catch-pose regime. It is after ruling out the dynamic bowel obstruction. Then the next is going to be the cancer. The most common site for the cancer in the West population is going to be the cardia, while in Asians it is going to be the proximal part, while in Asians it is going to be the distal part. Associated with the true polyp of the adenomatous polyp, most common gastric polyp that is seen in H. pylori is the metaplastic polyp. Now talking about the cancer classification in intestine, there is Lawrence classification, that is intestinal versus diffuse. So in intestinal, it is going to be this particular part is from stomach. So the Lawrence classification is used. In the Lawrence classification, there is intestinal cancer or diffuse cancer. So intestinal cancer is more common in males, while diffuse in females. Familial, environmental in intestinal, and in diffuse it is of familial origin. On histopathological examination in intestinal cancer, there can be glands, so spread is hematogenous, and mutations is microsatellite instability. While in diffuse, there are signet ring cells, spread is lymphatic, and epsilon cadherin mutation is seen. Now there are differences between early gastric cancer and advanced gastric cancer. In early gastric cancer, classification uses the Japanese classification, while in advanced gastric cancer, there is a Borman's classification. Extent for early gastric cancer is above the muscular layer, and the muscular layer is breached in case of advanced gastric cancer. The type 1 is the best prognosis. Type 4, it is called as the linitis plastica, or the leader bottle appearance, or it is also called as the mother of pearl appearance. If it is associated with chromosomal instability, it has got the best prognosis, but however it is associated with genetic instability, then it is worst prognosis. Clinical features of gastric cancer are the LODES. So LODES stands for the lump, O stands for gastric outlet obstruction, E stands for anorexia, D stands for neodyspepsia, and S stands for the silent. That is basically asymptomatic patient. The atypical presentation of the different lymph nodes that are affected. So Sister Mary Joseph nodule where periumbilical metastasis is seen. Then Crooked-Burke's tumor where ovarian bilateral ovarian neoplasm is seen. Then iris nodules are left axillary. Then Virchow's node is left supraclavicular or trochleus sign. Then Blummer shelf, its pelvis or pouch of Douglas. Migratory thumb of Levi is also called as Trousseau syndrome. It is associated with pancreatic cancer most commonly. In dermatopresentation, lacertoid sign and trypanosomes. Diagnosis endoscopic biopsy, that is for stomach cancer. Investigation of choice for overall staging is PET-CT. TNM staging is endoscopic ultrasound. Similar, these two things are similar to esophageal cancer, and the most common site is going to be the antrum of stomach. Then the TNM staging is also similar to esophageal cancer: T1A mucosa, T1B submucosa, T2 muscularis, T3 subserosal, and T4 is into the adjacent structures. Most common site of metastasis is into the liver. Then surgery of proximal margin of 5 cm and distal margin up to the pylorus is maintained in total gastrectomy. Distal or subtotal gastrectomy is also done. Then the amount of lymph nodes that are removed for Japanese station D1, there is 1 to 6 lymph nodes, D2 1 to 15. Minimum number of lymph nodes that are removed in gastric surgery are 16, while in esophageal cancer it is 15. Followed by total gastrectomy, you have to go for esophagojejunostomy direct. Now, where are these first 6 lymph nodes located? So first is there in the right paracardium, second is in left paracardium, then the third is in along the lesser curvature, the fourth is along the greater curvature, fifth is above the pylorus, and the sixth is infrapyloric in nature. Then the chemotherapy is 5-fluorouracil cisplatin. Radiotherapy is given at the stomach bed, and pembrolizumab, that is the PD-L1 inhibitor, is the new immunotherapy agent that is given. Apart from that, other types of cancers they include the GIST, gastrointestinal stromal tumor, origins from the pacemaker cells of Cajal. Most common site is going to be the stomach, that is along the midgut. Then this it is more of a sporadic than familial. So in the sporadic associated Carney's triad, that is GIST, paraganglioma, and pulmonary chondroma. In familial, it is associated with GIST and paraganglioma. The clinical features are upper GI hemorrhage. The spread is local or hematogenous through the liver. Management is investigation of choices contrast and on CT. Biopsy classification is the Fletcher's classification based on size and mitotic figures. Immunohistochemistry, the most common is the CD7 or CK17. Most specific is the DOC1, and the wild type, that is just negative for CD113, CD34. And management for benign lesions is the wedge resection or the edge resection, while malignant it is surgery plus chemotherapy, that is imatinib or sorafenib. Then lymphoma, the most common is the non-Hodgkin's lymphoma, that is the DLBCL, which is large B-cell lymphoma. The B-cell associated with B-cell symptoms like fever, night sweat, weight loss. The diagnosis is by biopsy, and management is the R-CHOP regime rituximab. C stands for cyclophosphamide, H stands for hydroxydonorubicin, O stands for oncomine, and the P stands for the prednisone. Then the next is maltoma, the most common site is stomach. For low-grade maltoma, H. pylori eradication, and for low-grade again the R-CHOP regimen is used. Then very important is the volvulus at the level of stomach. It can be of two types, organoaxial or mesenteroaxial. Organoaxial, it is associated with rolling type of hernia, and it is the most common type. Rolling type of hernia is the type 2 hernia, that is esophageal hernia. Investigation of choice is stable CCT, then stable patient contrast study. Then organoaxial volvulus is associated with Bouchard's triad. So Bouchard's triad says that retching, pain, and inability to pass the Raleigh tube. Then the management, if it's a viable, then go for gastropexy, that is derotate. If it's unviable, resection and anastomosis is done with reconstruction. Then if it's a mesenteroaxial, it is perpendicular to axis and cascade sign is seen. The trichobezoar, it leads to gastric outlet obstruction. If it's a small endoscopic removal, large surgical removal. Then there is something called Rapunzel syndrome, where this trichobezoar, it extends into the duodenum. Then the next, coming back to the intestine, so the next topic is going to be the stomas. So in the stomas, there are two types of stoma. So either there is ileostomy and a colostomy. Either stomy, it leads to more of a liquid output, while the colostomy leads to semi-solid output. Skin excoriation is more in ileostomy as compared to colostomy. Fluid and electrolyte imbalance is also more common in ileostomy as compared to colostomy. The ease of management is more for colostomy. Then technical difference is that in ileostomy there is a pouting that is done, that is raised margins, while the flushed margins are seen in case of colostomy. Then site is the right iliac fossa for ileostomy. For colostomy, if it is going to be a sigmoid colon, then the left iliac fossa, and if there is a transverse colostomy, then epigastrium region. Then position, it should be away from the bony landmark. Then the types, it's a single barrel or end colostomy. Then there is double barrel or loop wherein the two ends they are joined to each other. Then temporary stoma formation, it is seen in Hartmann's procedure, wherein after 6 to 8 weeks again the operation is done. Then permanent stoma formation is done in API, that is abdominoperineal resection. Complications, the most common complication is the skin excoriation. Then the earliest is going to be the necrosis, prolapse, retraction, and herniation. So there is a loop herniation more than the herniation is more common in the loop stoma as compared to the end stoma. And the most common long-term complication is also the herniation. And the next is the short bowel syndrome. So short bowel syndrome is less than 200 centimeters of the bowel length. It is less than 100, then that is called as a net secretors. If it is more than 100, that is called as a net absorbers. Then the most common cause is going to be the Crohn's disease. Then AME, that is acute mesenteric arterial embolism, trauma, atresia. So most common cause of short bowel syndrome is Crohn's disease. Then bacterial overgrowth. If ileum is patent and if the jejunum is gone, then ileum can adapt. But if the jejunum is present but the ileum is absent, that can lead to vitamin B12 deficiency. Ileocecal junction is intact and that meaningful absorption is present. Management, long-term total parenteral nutrition, transplantation should be done. Medications such as teduglutide, which is the GLP-2 agonist, can be given. Then the surgery is the Bianchi's procedure, or the step, that is submucosal tunneling, that is serial transverse enteroplasty is done. That increases the surface area. The diverticular disease, wherein a false diverticulae are formed along the mesenteric border. The most common site is going to be sigmoid colon. Most common cause of the lower GI hemorrhage and associated with constipation. Now in barium enema, this diverticulosis is, it forms a sawtooth appearance. Complications is it leads to bleeding, which is more common on the right side, and this is because of the superior mesenteric artery. Investigation of tricycity angio, management is embolization followed by resection. Diverticulitis, it is more common on the left side. It has a staging that is called as Hinch's staging. So in stage 1 and 2, so in stage 1 there is a pericolic abscess, stage 2 there is a pelvic abscess, for that pigtail catheter drainage is used. For stage 3 and 4, it is associated with peritonitis, and in stage 4 this peritonitis because of fecal matter or fecalith formation. Emergency laparotomy is done followed by Hartmann's procedure. And other complications can be colorectal cancer, or the other complication for the diverticulosis is going to be colovesical fistula, wherein this fecal matter comes to the bladder. It is more common in males and can lead to pyelonephritis. Then the next, that is going to be the inflammatory bowel disease, wherein we discuss what is the difference between the Crohn's disease versus ulcerative colitis. So Crohn's disease is more commonly seen in 20 to 40 year age group, and the second peak happens more than 70 years. Ulcerative colitis is more common in 25 to 40 years of age. The gender, it is more Crohn's disease is more common in females, while ulcerative colitis is more common in males. The risk factors for Crohn's disease are smoking, refined food, and not 2 or card 15. While in ulcerative colitis, it is the smoking is actually going to be protective. Bowel involvement in Crohn's disease is transmural. Skip lesions are present. Here it is only mucosa and submucosa and continuous spread. Anal involvement, that is anal fissures and all, is present in Crohn's disease. It is absent in ulcerative colitis. Rectum is involved in ulcerative colitis. It is sparred in Crohn's disease. Then the strictures of the fistulae, they are present in Crohn's disease. Pseudopolyps in ulcerative colitis. Crypt abscess in ulcerative colitis. Toxic megacolon is ulcerative colitis. Toxic megacolon, where the size or the diameter of the colon is more than 6 centimeters. Then the cobblestone appearance, creeping fat in Crohn's disease. The granulomas, non-gestating granulomas, are seen in Crohn's disease. The earliest sign of Crohn's disease, that is the aphthous ulcers, it is seen in Crohn's disease. And also the streak sign of Cantor is a radiological sign of Crohn's disease. Acute appendicitis, mimicking lesions are also seen in Crohn's disease. While the radiological signs of ulcerative colitis, they include the lead pipe or Gardner's rigidity. Ulcerative colitis has more risk of turning into a cancer as compared to Crohn's disease. And classification that is used for Crohn's disease is the modified Montreal classification. Diagnosis is by biopsy. Then the stools mild, moderate, severe, and fulminant. If there are less than 4 stools, mild. When there are more than 4 stools, which are having no, there are no systemic. Then severe stools, more than 6 stools, having systemic signs, and fulminant stools, that is more than 10 stools with the presence of toxic megacolon. Then the next is going to be the Crohn's disease. The management for Crohn's disease, the medical management is steroids, and 5-ASA, sulfasalazine, infliximab, and vedolizumab. Surgery, there is no definite surgery. For perianalysis, the sit-on surgery can be done. Then the ulcerative colitis. Ulcerative colitis, the medical management is steroids, 5-ASA derivatives, and monoclonal antibodies. Surgery can be done if toxic megacolon, obstruction, or cancer is present, and there is a definite surgery that is called as the total proctocolectomy along with IAPA, that is ileoanal pouch anastomosis, where a J-shaped pouch is created. The most common complication is pouchitis. Most common cause of death is adhesive obstruction. Extraintestinal manifestations. So in the skin, there are erythema nodosum, pyoderma gangrenosum, oral ulcers, hepatobiliary primary sclerosing cholangitis. Then you have the renal, that is nephrolithiasis, calcium oxalate nephrolithiasis, that is seen in Crohn's disease. What are the complications that persist even after surgery? That is the associations of ankylosing spondylitis and primary sclerosing cholangitis. They persist even after the surgical removal of the disease. Then the next pathology is angiodysplasia. Angiodysplasia is the second most common cause of lower GI motility. It is found in 6th to 7th decade. More common in the right side as compared to the left side. Then there is a syndrome that is associated. It's called a Haydes syndrome. In Haydes syndrome, there is angiodysplasia along with aortic stenosis and along with von Willebrand disease. Most common side is going to be the cecum. Diagnosis, colonoscopy or capsule endoscopy. Management is ligation of the vessels. Lower GI hemorrhage presence in medulla. There's a risk of fissure, hemorrhoid, or polyps. Colonoscopy up to cecum can be done. Bleeding in stomach or duodenum, capsule endoscopy, technician 99 per technique scan, and endoscopy capsule. Then the thumb printing sign of the abdominal X-ray. Thumb printing sign of abdominal X-ray is seen in ischemic colitis or pseudomembranous colitis. Then ischemic colitis more common in the splenic flexion. Next is the bowel TB. The bowel TB is of two types, either ulcerative type or a hyperplastic type. In ulcerative type, the immune response is less. In hyperplastic type, it is more. Most common site is terminal ileum. Here it is the most common site, terminal ileum as well as the ileocecal junction. It forms a gooseneck deformity on the X-ray, and a string sign of Cantor is also present. Management is right hemicolectomy. Now the ulcerative type, it forms two important ulcers, either a TB ulcer or a typhoid ulcer. Typhoid ulcer is longitudinal, TB ulcer is transverse. The complications for TB ulcer is stricture, for typhoid ulcer it is perforation. Then management is anti-tubercular therapy. The strictures, they are close to even the sexual anastomosis. Strictures are far apart than stricture of plastic. For typhoid ulcers is the emergency laparotomy along with the sexual anastomosis. Then the next is the fecal fistula. It's a high output fistula. It is more than 500 cc. A low output of less than 200 cc of material is coming out. Then fistula closure. It can either be a spontaneous closure or a non-spontaneous closure. Spontaneous closure can happen if the fistula is present in the esophagus, duodenum, or the abdominal wall defect is less than 1 centimeter. If it is present in the stomach, ileum, or the abdominal wall defect is more than 1 centimeter, there are less chances of spontaneous closure. The fistula tract, very important. The fistula tract is long, that is more than 2 centimeter, there are more chances of spontaneous closure. No defect in the abdominal wall, albumin more than 25, friend factor negative, output are less than 200. In all these cases, there are chances of spontaneous closure. Management is conservative. Then there is a principle that is called a SNAP principle, where we have to manage the skin excoriation, sepsis control, nutritional build-up, anatomical delineation, and the planned surgeries done. Next is going to be the polyps. So in the polyps, there are different types of polyps: inflammatory polyps, hyperplastic polyps, and hematomatous polyps. Inflammatory and hyperplastic polyps, both of them, they are not premalignant in nature. Inflammatory polyps are the pseudopolyps which are seen in ulcerative colitis. Hyperplastic polyps is the most common overall, and these are formed due to decreased epithelial turnover. Hematomatous polyps, they are the syndromes associated with it are juvenile polyposis syndrome because of SMAD4 gene defect, autosomal dominant in nature. Then this is the arborizing pattern that is seen in Peutz-Jeghers syndrome, which is again autosomal dominant, which is caused because of LTB1 or STK11 gene defect on chromosome 19. The most common site is going to be the jejunum. It leads to perioral melanosis and arborizing pattern. Clinical features: the most common is interception. It can act as a lead point and increases the risk of cancer. It increases the risk of pancreatic cancer about 100 times. Then Cowden syndrome, again autosomal dominant PTEN gene mutation on chromosome 10, not a pre-malignant condition associated with lipoma ganglioneuromas. Then Myers-Smith syndrome, or it is also called as Mannion-Rubalcaba syndrome. It is associated with macrocephaly or penile pigmentation. Cronkite-Canada syndrome is associated with alopecia and koilonychia. Then adenomatous polyp. Adenomatous polyp is again a pre-malignant condition. There are types, that is tubulus, villus, and tubulus. Tubulus is most common, while the villus is the one that is associated with carcinoma. Increased risk of carcinoma is seen when their type is villus, more the size and more the numbers, and sessile polyp has more risk of cancer. Then the classification that is called as the Hackett's classification. Villus polyps relate to hypokalemic metabolic acidosis because it secretes the bicarbonate and that is excreted out. Management is endoscopic resection. Then adenocarcinoma sequence is given by Vogelstein, and that is AK53, that is ABC gene mutation, then KRAS gene mutation, and then the P53 gene mutation, which is a late gene mutation. Then the next is the FAP, that is familial adenomatous polyposis, autosomal dominant APC gene, chromosome 5. More than 100 polyps means 100% chance of carcinoma. Then most common site is going to be the rectum. Extraintestinal manifestation, or the CHRP, that is congenital hypertrophy of the retinal pigment epithelium. Then the variants are Gardner and Turcot. In the Gardner, there are increased number of teeth. Then the osteomas, sebaceous cyst, despite tumor. Turcot syndrome is associated with glioma and medulloblastoma. Management is total proctocolectomy along with ileoanal pouch anastomosis. Screening, if it's a first degree relative is a case of colorectal carcinoma, then the first genetic testing should be done for the APC gene. If it is present, then the screening should be done for every 10 years with the help of colonoscopy. Then the next is HNPCC, that is hereditary non-polyposis colon cancer. Hereditary non-polyposis colon cancer is associated with microsatellite instability, MLH and MSH gene. MSH gene, out of which is most common. Then Lynch 1, it is colonic cancer, while Lynch 2, it has got extra colonic cancers, out of which the most common is the uterine cancer. Then the criteria that is used is the modified Amsterdam criteria for HNPCC. In HNPCC, the tumor initiation is normal, but however the progression is fast. In familial adenomatous polyposis, the tumor initiation is fast, but the progress is normal. Then MUTI associated, it is autosomal recessive, it increases the risk of cancer, and 2-year colonoscopy follow-up is required. Then colorectal cancer. Colorectal cancer, the risk factor for colorectal cancer is going to be retrosigmoid anastomosis, which increases the chances by about 100 times. Protective are the NSAIDs, metformin, and the selenium-rich diet. Screening should be started from 50 years and then 10 years before the younger relative diagnosis. Colonoscopy should be done once in 10 years, and colonoscopy can view up to 110 to 140 centimeter up to the cecum, while the flexible sigmoidoscopy should be done once in 5 years and can view up to 60 centimeters. Fecal occult blood test, that is called as Guaiac test, can be done. Most common site for colorectal cancer is going to be rectum followed by the sigmoid colon. Then there are different types. So the exophytic type or ulceroproliferative type, it is seen on the right side, where on the right side there is a bleeding and the increased chances of iron deficiency anemia, and there is more amount of liquid matter in the fecus. While in the left sided colon cancer, it has a apple core or a napkin ring type of lesion. Investigation of choice is colonoscopic biopsy, not only colonoscopy but colonoscopic biopsy. MRI is needed for TNM staging. For overall staging, PET-CT. Tumor markers, carcinoma, embryonic antigen. Most common site of metastasis is liver. Minimum lymph nodes removed at 12. T1 is mucosa, submucosa. T2 is muscular. T3 is serosa. T4 adjacent. That is the same throughout the GIT. Then the classification, that is Duke's classification or Asler-Kohler classification, where A stands for mucosa, submucosa, B stands for the muscle layer, C stands for lymph node as well as muscle layer, and D stands for distant metastasis. So Duke's or Asler-Kohler classification based on the depth of invasion and the lymph nodes. Then next is going to be the surgery. So how do we do the surgical management? So here this is the intestine that is shown. These are the that supply. So right side is supplied by the superior mesenteric artery that gives a ileocolic branch, then right colic, right middle colic, left middle colic, left middle colic, and a left colic, which is a branch of inferior mesenteric artery. It is joined by marginal artery of Drummond, and marginal artery of Drummond is the one where the lymph node mapping is done. Then Sudex point is a watershed area, and the Griffiths point of the splenic flexure. This is the most common site for ischemic colitis. Now, very important, on the basis of this only, the location of the tumor can be found out. So the location of the tumor is at the cecum. Then right hemicolectomy is done, and the right hemicolectomy 10 to 12 segments of the is removed. Then the cecum is removed. Right hemicolectomy is the ascending colon, and the right part of the transverse colon is removed. The arteries that are ligated are the ileocolic artery, then the right colic branch of the middle colic artery, and the right colic artery. Similarly, if the tumor location is along the ascending colon or the transverse colon, then in that case right extended hemicolectomy is done, where the ascending colon is removed and the cecum is removed. Similarly, the whole of transverse colon is removed, because anyhow the splenic flexure is a watershed area. So very important is this transverse colon. If the tumor lies in the transverse colon, then in that case also the extended right hemicolectomy is done. There is nothing called as transverse colectomy. If it lies on the splenic flexure, then left hemicolectomy is done, and if it lies along the sigmoid colon, then isolated sigmoidectomy is done. Now talking about the rectal cancers and its management. So rectal cancer, the earliest feature of rectal cancer is the rectal bleeding. Now this is how the anatomy is. The lowermost limit that is called as the anal verge. Then this is the anal rectal ligament, which is formed by the levator ani muscle. Then along the dentate line, if the lesion lies above the dentate line, it is painless. Below the dentate line, it is painful. External anal sphincter and internal anal sphincter, it lies there. Then the margins of clearance that should be maintained is proximal 5 cm, distal 2 cm, radial 5 cm. If the tumor is more than 5 cm from the anal verge, then in that particular case we go for low anterior resection. The sphincters, they are retained in this particular procedure. There is no urinary incontinence. But however, less than 5 cm from anal verge, then abdominal perineal resection is done. Sphincters are resected, and that will lead to urinary incontinence, fecal incontinence. So for that we need to go for permanent end colostomy. Minimum lymph nodes removed in rectal cancer are 12, and then there is another modality called as statomy, that is transanal total mucosal resection, total mesorectal resection. So in that there is a notes procedure, and here it is done for T1 T2 operation, where the sphincters are preserved. Similarly, for elderly patients, frail patients, Hartmann's procedure is done. Then the nerve injuries, for high IMA ligation, the hypogastric nerves are getting involved, that will lead to retrograde ejaculation. Lateral stalk, then pelvic plexus getting involved, that will lead to erectile dysfunction or impotence. Anterior dissection, that will lead to prostatic plexus damage and sexual bladder dysfunction. Not so important. Okay. In emergency procedures with obstruction, then endoscopic stent replacement or Hartmann's procedure, Paul Collick's procedure is done. It's a T3 D4 tumor metastasis, lymph node status is positive. Then the chemotherapy that is given is FOLFOX regime or FOLFIRI regime. Then the radiotherapy is done only for the rectal cancer and not for colon. Immunotherapy, bevacizumab, that is the VEGF inhibitor, cetuximab, that is anti-EGFR, pantibumab, which is anti-EGFR, and the pembrolizumab, that is PD-L1 inhibitor. So these immunotherapy agents can also be given. For metastasis, the most common site is going to be liver, so surgical resection of the liver metastasis can be done if the functional liver reserve is more than 25%. Most important prognostic factor in rectal cancer model is going to be lymph node status. Anal cancer, the most common type of anal cancer is going to be squamous cell carcinoma. Adenocarcinoma is rare, for that abdominal perineal resection is done. For squamous cell carcinoma, it is associated with human papillomavirus, HIV, homosexual, investigation of choices biopsy. The regime that is followed is called as the Negro regime. 1 month prior chemotherapy is given, and go for abdominal perineal resection. The chemotherapy involves the 5-fluorouracil and the mitomycin C. Next is going to be the rectum and anal canal. So in the rectum and anal canal, we know that there is a denonvillous fascia which separates it anteriorly from the prostate and vagina, and posteriorly there is a Waldes fascia which separates it posteriorly from the cecum. The anatomy of rectum, it is about 20-16 centimeters in length. Lower part of the rectum is not covered by peritoneum, and about the dentate line there are columns of Morgagni, and they are covered by cysts, which are crypts, which are the site for abscess. Then the sphincters, the internal sphincter is supplied by S2, S3, S4, which is a sympathetic nervous system. External sphincters, they are supplied by the pudendal nerve, S2, S3, S4. Then the pathology, the first pathology is the hemorrhoids. Hemorrhoids, they are hemorrhoid cushions or the arterial channels for internal hemorrhoids are located at 3 o'clock, 7 o'clock, and 11 o'clock position. That is left anterior, right posterior. The most common cause of bleeding per rectum, painless bleeding per rectum, is going to be the internal hemorrhoids. External hemorrhoids are painful. Similarly, thrombosed and hemorrhoids are also painful in nature. Investigation of choice is the proctoscopy. The grading is done to grade 1, 2, 3, 4. So grade 1 is where the bleeding is present but no prolapse. For that, lifestyle changes or sits bath is preferred. Now grade 2 is prolapsed but spontaneous reduction happens, and for that banding greater than sclerotherapy is done if it is above the dentate line. That is internal hemorrhoids. Then grade 3 where the prolapse is manually reduced, and grade 4 is remain prolapsed. For that surgery is done. So what are the surgeries? Open hemorrhoidectomy, that is called as Milligan-Morgan procedure, and the closed hemorrhoidectomy, that is Ferguson procedure, which are obsolete. Stapled hemorrhoidectomy, that is surgery of choice, and Doppler guided ligation of the hemorrhoid arteries is also done. Most common complication is urinary retention because of the perceived pain. The next pathology is the anal fissure. Anal fissure is present below the dental line because of which it is painful, and due to this, proctoscopy or digital rectal examination is contraindicated. So the investigation of choice is just the inspection. The most common side is 6 o'clock midline posterior, and investigation of choice is external inspection. The skin tag, or that is also called as the sentinel pile, is because of the accumulation of the lymphatics. Management is conservative by giving a 2% xylocaine gel or litiazem cream. Surgery is lateral anal sphincterectomy, which is in which the internal sphincter is cut, and anal advancement flaps. In pilonidal sinus, or it is also called as the jeep driver's disease, the most common site is going to be the natal cleft, where there is an inward growth of hair. Management is analgesics or drain the abscess, or if not, the surgical repair is by a Z+D or a Limburg's flap, rhomboid flap, Bascom's technique, or Karyadaki's technique. Then the next is anorectal abscess. In anorectal abscess, there is a fluctuation, which is going to be a late sign, similar to the parotid abscess or any other thing. Management is incision and drainage. If there is a poorly drained abscess, then that will lead to fistula or sinus. Multiple fistula that can be formed, or multiple sinuses that can open into the perianal region, that is called as water can perineum, and a rule for them is going to be the Godsall rule. The causes of them are the Crohn, Crush, cancer, and Koch. So Crohn's disease, Crush, that is trauma, cancer, and Koch, that is TB. Investigation of choice is MRI or fistulogram, and past classification is used. Then if it's a low fistula, then fistulectomy, fistulotomy, lift procedure, that is ligation of fistula tract, or a WAFT procedure, that is video assisted fistulotomy. Then high fistula, then in that particular case Seton's surgery is used, where we preserve the continence. Draining the Seton is done in case of Crohn's disease. Then rectal prolapse. It can be either partial or complete. Partial prolapse it is seen in children, and complete prolapse is seen in adults. In partial prolapse, only the mucosa is prolapse. Management: if a mother comes with a child having rectal prolapse, then the first, if it's a case of first prolapse, and digital reposition, that is conservative management, is done. If it's recurrent, then Thier's wiring or sclerotherapy is done. For complete prolapse, however, only surgical management is required, and it can be either perineal or abdominal approach. Perineal approach, it is easy, as having less complications but more recurrence. Generally done in elderly or frail patients. The management includes the Thier's wiring, Delorme's repair, or Altimere's repair. In abdominal approach, where there is a decreased recurrence chances, it is done in young and fit patients. Wells and Repstein rectopexy and Frickman-Goldberg operation is done. Management: most common is the constipation. Apart from that, bleeding, injury to the nerves, or recurrence is seen. The next is SRUS, that is solitary rectal ulcer syndrome. It is more commonly seen along the anterior wall of the rectum. The investigation of choice is biopsy. It helps us to rule out ulcer, but overall the radiological investigation of choice is the defecography. Management is the STAR, that is stapled transanal rectal resection procedure. The different devices and their lens. Anoscope, it is used to visualize the 8 centimeter. Proctoscope is used to visualize 10 centimeter. A rigid sigmoidoscope for 25 centimeters. Flexible sigmoidoscope 60 centimeter. Colonoscope 110 to 140 centimeter. Anorectal malformation associated with bacterial syndrome. Investigation of choice is the MRI. Invertogram. After 24 hours, the metallic coin it is placed at a proposed site of the rectum and X-ray is taken in inverted position. If it is less than 2 centimeter, then it's a low anorectal malformation. If it is more than 2 centimeter, it's a high anorectal malformation. For low anorectal malformation, it's the PSARP, that is posterior sagittal anorectoplasty. And for high anorectal malformation, the first, that is diverting colostomy, and the second definitive surgery, that is PCRP. In the males, it is associated with fecal matter through urination that will lead to recurrent UTI, and in the females, it can lead to rectovaginal fistula. Then the next topic is going to be the appendix. The site of appendix is generally located by using the junction of the three tinea coli or the field of Travis and forms the ileocecal fold. The most common site is going to be the retrocecal in position, and least common is going to be post-ileal in position. McBurney's point is present from an imaginary line joining the umbilicus to the anterior superior iliac spine. It is present at the lateral 1/3 and the medial 2/3. Appendicular artery, which is a branch of the iliopulvic artery, it's the end artery, and it is the most common site of thrombosis. And most common thrombosis happens at the level of tip of appendix. Then the next is the accessory appendicular artery, which is also called as the artery of Schistulamm, and the branch of cecal artery. Acute appendicitis, most common cause of obstruction. Then fecal is the most common cause for obstruction. Then foreign body food particle and a roundworm or the ascaris infection. It presents with a triad of called as the Murphy's triad, where the pain is the most common. Initially, the pain is in the epigastric region, in the umbilical region, which is the visceral pain, and then it goes into parietal, that is right iliac fossa. That is associated with nausea, vomiting, and as well as in fever. Then the pointing sign or the rousing sign. The pointing sign means when the patient points towards the right iliac fossa. Rousing sign, which is when you press the left iliac fossa, there is a pain in the right iliac fossa. The Swas sign or the Cope-Swas test is there is a pain in the right iliac fossa on the right sided hip flexion against the resistance or the hyperextension of the right hip. Obturator sign is there is a pain when we internally rotate the right hip. Then Dunphy sign, pain while cuffing. Aron sign is pain in the epigastrium upon right iliac fossa press. Tenhorn sign is pull the right testis, is pain in the right iliac fossa. Then the most common site of appendix is the retrocecal, wherein the rigidity is absent but the psoas test is present. Then in the pelvic site, the obturator test is present. It more often leads to rectal or bladder irritability, because of which there are increased chances of micturition and all. Then post-ileal is the least common, it's the most difficult to diagnose. Investigation of choice in adults is ECT, in children is ultrasound. Ultrasound, it will show blind tubular structure, periappendiceal fluid collection, then probe tenderness, and appendicolith or fecolith can be seen. Perforated appendix, the most common organism that is seen is the Bacteroides fragilis. And then the classification or the staging that is used, that is called as the modified Alvarado or the Mantle score. The score is out of 10. It is based on signs, symptoms, and lab findings. So in the symptoms, Mantrals, M stands for the migration of the pain to the right iliac fossa, anorexia, nausea, vomiting. Then the tenderness, which has got 2 points. Then rebound pain, elevated temperature. L stands for leukocytosis, which are 2 points, and S stands for the shift of the WBC to the left, which is got 1 point. So together 10 points. If it is less than 5, it is unlikely. If it is 5 to 8, then that is ultrasound is required. If it is 9 to 10, then it is very likely of appendicitis. Differential diagnosis of appendicitis. In case of children, the differential diagnosis is mesenteric adenitis due to Yersinia infection is the most common. Then then intersubsection, Meckel's diverticulitis. In case of adults, it is AG, bowel obstruction, or ureteric colic. In case of females, it is metal stenoids, pelvic inflammatory disease, or the ectopic. Management is either conservative or surgical management. Talking about surgical management, there are 2 types: open appendicectomy and closed appendicectomy. In open appendicectomy, there are different incisions that are made. So the first is called as this incision. It is called as the grid iron incision, which is a muscle splitting. while similar incision on the right side, that is called as a Rutherford incision, which is a muscle cutting incision wherein the external oblique, internal oblique, and transverse abdominis are cut. Then there is a lower midline abdominal incision, and this incision is called as a Lanz incision or bikini incision. This is about 2 cm infraumbilical. In laparoscopic, there are 3 ports that are made. So one is the infraumbilical port, one is the suprapubic, and another is in the left iliac fossa. Now, while performing appendicectomy, there can be different scenarios. The first scenario is the appendix is not inflamed. In that particular case, look for the Makers diverticulum. If it is present, then remove it, or if it is not present, then in that case, go for appendicectomy. If it's an inflamed base, then do not crush the base. Bursting suture or Z stitches applied. If the cecal wall is found to be gangrenous, then right hemicolectomy is done. If in a Crohn's disease the cecum is healthy, appendicectomy. If cecum is inflamed, then don't go for right hemicolectomy by removing the cecum because it increases the risk of fistula. So we have to go for conservative approach. In complications of appendicectomy, it can lead to bleeding. The most common is infection at that site, injury to hypogastric nerve, pyemia, pelvic abscess, and stump appendicitis. To prevent the stump appendicitis, the maximum stump length that can be kept is 0.5 cm or the 5 millimeters. Then appendicular perforation. Appendicular perforation, it is caused because the normally the greater omentum, which is the policeman, it provides protection. If there is any pathology associated with it, that leads to appendiceal perforation. And management, in that particular case, you have to do emergency appendicectomy by lower midline incision first. Then pregnancy, it is the most common non-obstetric abdominal emergency. The ultrasound is done, and finally MRI. You can never do CCT in pregnancy. And management, you have to go for laparoscopic appendicectomy in all the 3 trimesters. Right, it is different from lap cholecystectomy, which is done only in second trimester. Then appendicular lump. Appendicular lump, that is a jumbled up mass. If it is seen on the appendix, then you have to follow conservative regime that is called as Oshner-Sharon regime. In Oshner-Sharon regime, if the patient is found to have a stable vitals, if the patient is recovering, then interval appendicectomy can be done after 6 weeks. If it's going to be abscess, right, vitals are unstable, then pectoral drainage is needed. Appendiceal tumor. Appendiceal tumor, most common is the neuroendocrine tumor. Most common side is going to be deep of appendix. It's an incidental diagnosis. Management, it depends upon the size of tumor. So most important prognostic factor is going to be the size of the tumor. If it is more than 2 centimeters in size or it is close to the base, in that particular case, right hemicolectomy is done. But if it is towards the appendix, if it is less than 2 centimeter, then that also there are 2 types. If it is less than 1 centimeter towards the tip, then only appendicectomy is done or observation can be done. If it is 1 to 2 centimeter poorly differentiated, then go for right hemicolectomy. Then the goblet cell carcinoma, it's not a neuroendocrine tumor. Management is right hemicolectomy. Then mucocele. Mucocele is an epithelial tumor. It can be divided into low grade, diffuse, and PMCA. Diffuse is non-invasive in nature. It is local invasive actually, and PMCA is distal metastasis. A very important condition that is called as the pseudomyxoma peritoniae. So pseudomyxoma peritoniae is the accumulation of a mucinous-like substance, and there is a progressive distension of the abdomen. Investigation of choice is CCT. Right, it is also seen in bilateral ovarian neoplasms. Now, very important is the management. There is a debulking surgery, the cytoreductive surgery, wherein R1 or R2 resection is done. That is microscopic disease left behind or gross disease is left behind. Here we do appendicectomy, then right hemicolectomy. In case of females, total abdominal hysterectomy in bilateral salpingo-oophorectomy, oventectomy, and stripping of the peritoneum is done. And after doing this, you have to put the patient on HIPEC, that is hyperthermic intraperitoneal chemotherapy, where the temperature is 40 to 41 degrees Celsius. The chemotherapy agents are mitomycin C, paclitaxel, and you have to drain it after 60 to 90 minutes. So this is all about the gastrointestinal surgery.